So today's presentation gonna be about the review and capacity board that hopefully will start next week, and just a little bit about assessing capacity in general. Okay. So the objective is gonna be basically first to define capacity and compare the legal definitions in Kuwait and Western legislations, know the legal test in the local jurisdiction, understand the importance of capacity assessment, define informed consent, know the hierarchy for substitute decision makers, and we'll talk a little bit about the review and capacity board that we'll make at the hospital. Okay, so what is capacity? Okay, so what I mean here is mostly capacity to treatment. Okay, and this is the thing that we assess: is the patient capable regarding treatment decisions or not? Okay, so it is presumed. Okay, so everyone is capable unless proven otherwise. So every patient we see is basically capable unless we prove that he is not capable because of a mental disorder. So it is presumed, it is time specific, okay? So when we say that this person is not capable, we cannot say he's not capable for life. He's not capable at the meantime, at the time of the assessment. He may be gonna be capable with treatment, okay? It is task specific, okay? So when we say capacity, what do we mean by that? So we cannot just say he's not capable. We have to specify he's not capable for treatment. He's not capable for finances, okay? He's not capable for custody. He's not capable for signing contract, okay? But the thing that it's important to us is the capacity regarding treatment. So we say the patient is not capable regarding treatment decisions, so we have to specify. Okay. It is also treatment specific. We cannot just say the person is not capable regarding treatment. What treatment? Is it for diabetes? Is it for psychiatric treatment? So again, we have to specify the person is not capable regarding treatment for psychiatric medications or psychotropics in general. Okay. So maybe the person is, for example, capable regarding insulin. He knows why he needs insulin, because of his delusions or hallucinations and all that. I mean, he doesn't know why he needs Ziproxy, for example. Okay. It is functional, basically. Diagnosis by itself does not indicate incapacity. Just because a person has schizophrenia doesn't mean he's not capable. Okay. So we have to assess capacity. So this is taken from Ontario Healthcare Consent Act. This is just for reference. Okay. Just to give you an idea how things work in different countries, because unfortunately in Kuwait legislations things are very vague. There is no specific law about capacity. Okay. So in the Healthcare Consent Act in Ontario, and basically this is true for all provinces within Canada and the States and all that. I mean, this is basically what's done in all other countries, that you cannot basically start a treatment without consent. You can't. There is no such thing. You have to take consent. This is a basic right for every patient. You have to take consent from the patient regarding treatment before starting a medication. And any doctor should do that, not just psychiatrists. Any physician, basically, who is proposing a treatment, a family doctor proposing insulin, has to discuss insulin treatment with the patient. You guys want to start Ziproxy, you have to discuss Ziproxy with the patient. This is a very basic right. Okay. So basically it says that he or she is of the opinion that the person is capable with respect to ensure. So basically the law says that if so you assess capacity, and depending on that, you see if the person is really capable or not. So if capable, then that's it. Basically, you take whatever the patient says, whether he agrees with the medication or not. If he's not capable, then you go to the substitute decision maker or his family, basically, discuss the medication with them. Okay? But you have to discuss the medication. Okay? So either the patient or his family in case the patient is not capable. So the test that we usually use, basically when we say the person is capable, what do we mean by that? Two things. The test basically has two elements. The first element is understanding the information. Okay? The person needs to understand why he needs Zyprexa. What is the information about Zyprexa? What is the side effects about Zyprexa? What is the prognosis with and without Zyprexa? Okay? This is the first element, understand. And usually most psychiatric patients, they're okay with understanding. They know the information. Unless the person is demented, they have dementia or intellectual disability, then they fail the first element. Usually patients, psychiatric patients, fail the second element, which is the appreciation. Okay? They don't appreciate the risks and the benefits. Because of their delusions, they don't know they have an illness, so they don't know why they need Zyprexa. Yes, they know, they understand the information about Zyprexa, they understand it's antipsychotic and all that, but they don't appreciate why they need it. I don't need antipsychotic, I don't have any mental illness, I don't have any delusions, that's not true. So they do not appreciate, which is basically the reasonably foreseeable consequences of a decision or lack of it. Okay? So in Ontario, basically how they define this capacity, again, as we said, the first branch is to understand. This is the objective test. Basically, this is the cognitive ability. Okay, so whether the patient is able to process all the information. Okay, so unless the patient is basically demented or have intellectual disability, then they don't understand the information. The second branch is, are they able to apply the information to their own circumstances? This is the ability to appreciate. Okay, are they able, because for example of their delusions, they don't apply the information that they need, this antipsychotic, to them to help them reduce the delusions. They cannot appreciate that benefit. Okay, and they're not able to weigh the risks and benefits. They don't see any reason for it. Okay. So if a practitioner, and this is in general, any practitioner basically, any doctor, okay, believes a person is not capable, consider if a person is able to understand. So when we say the person understand those information about the condition, that he understands about schizophrenia, nature of the treatment, what is Zyprexa, antipsychotic, why, what's the reason for it, the risks and benefits of treatment. Okay, so you'll take this medication to lower the delusions, makes you have a better life with your family. Okay, and the risk, understand this. Yes, there's the side effects of the treatment. There is this risk of death, sudden death, for example, with Sudilect. Understand there is a QT. Elongation with Sudilect, you understand those information. Okay, and the alternatives. What's the alternative, for example, for giving them Sudilect? They understand. Yes, there's, for example, another antipsychotic. Okay, or for example, if for a patient with depression, we give him SSRI. They understand that there is an alternative. We can use CBT, for example, for if it's mild depression. So they need to understand this information. And then appreciate, basically, again, as we talked about it, to appreciate is basically to understand the condition itself. For example, that he has psychosis. He doesn't need to approve that he has schizophrenia per se. Okay, the patient does not need to approve with you the type of diagnosis, but he needs at least to have some awareness that he has a mental abnormality. Okay, and this is very important. Okay. So basically, you should not presume treatment incapacity based solely on a psychiatric neurological disorder, not just because a patient has schizophrenia, then we say he's not capable. You can't. You have to assess capacity. You can't rely just basically on disability. The person is mute, therefore he's not capable. No, you can't. Okay, you have to assess capacity. Or just because he's disagreeing with you or refusing your advice, that doesn't mean he's not capable. Or because of age, he's 80 years old, therefore he's not capable. No, you have to assess capacity. Or a request for alternatives, just because he's asking you what's the alternative for antipsychotic, that doesn't mean he's not capable. Okay. So the usual circumstances that give a reasonable belief of incapacity, again, not definite, you have to assess capacity, but I mean, you can think that this person may be incapable. Usually when there's in general psychotic disorders, like usually delusional thinking in general. If there is delirium, dementia, cognitive disorders, severe depression, for example, the person cannot really process the information, or impairment in general, whether due to drugs or alcohol. And this might be just a brief time where the person is not capable, and then he will become capable after the substance itself wears off. Okay. So what happens is basically when a health practitioner finds someone incapable, then you have to tell the patient, I think you're not capable regarding your treatment, and therefore I will assign a substitute decision maker. I will assign one of your family relatives to discuss the treatment with him. Okay? So you have to basically tell him. You don't just surprise him and then start him on treatment, and later on he will find out that basically you took the decision because you spoke to his father, for example, or his brother, and his brother gave you the green light. You have to tell him that I will speak to your family and take the permission from your family. Okay. At the same time, you have to involve the person, even after finding him not capable. You have to involve him in the decision. Okay, you should not just ignore him completely. Okay. Okay. So Kuwait legislation, basically, more specifically, there's nothing in Kuwait legislation that talks about treatment capacity itself. Okay. Therefore, I mean, the law itself is very vague. And honestly, mostly we depend on ethics rather than law, because ethics come first, and later on there's going to be legislations and all that. So if you guys think what you're doing is ethical, you're not basically harming the patient in any way, you're not doing it for personal reasons, then you should not worry about anything. Okay. If you're treating, if you're following all the guidelines, even if basically following the ethics and the regulations from other countries, what's the worst thing that could happen? You go to court and explain to them that you did it for good reasons. You wanted basically to treat the patient because he was at risk of harming himself or others. That's it. Okay? You can do that. You're not doing anything wrong. Okay? So, in Kuwait legislation, قانون الأحوال الشخصية, now we'll start talking in Arabic a little bit because of the laws in Arabic. فالولاية نوعين، هي ولاية على النفس وولاية على المال. الولاية على المال اللي هو financial capacity. Okay, you guys don't need to deal with it because we mostly deal with it at forensic psychiatry. اللي هو يولنا على موضوع الحجر زين في financial capacity. اللي يهمنا بالجنرال سايكاتري اللي هو الولاية على النفس. فالولاية على النفس هي تشمل، let me bring my pointer. So الولاية على النفس كذلك تشمل التطبيب. Okay, which basically means treatment, العلاج. Okay, فلما نقول ان الشخص يخضع للولاية على النفس الصغير والصغيرة إلى أن يبلغ شرعا أو يتم 15 من العمر عاقلين كما يخضع لها البالغ المجنون أو المعتوه. Okay. فالمجنون that are patients that we deal with. When we say that this person has schizophrenia, basically we mean جنون. Okay. أو المعتوه، في المعتوه اللي هو طبعا يعني التخلف العقلي أو حتى الدمنشيا يعني cognitive impairment. Okay. فلما نقول this patient is basically not capable for treatment decisions because of schizophrenia, for example, okay, or because of dementia, we're following the law, okay. So in this case, we say basically this person cannot take decisions for himself. In this case, we need ولي عليه، أو بالأصح دائما يسمونه القيم، okay. فالولاية على النفس اللي هي كذلك تتعلق بالتطبيب. Okay. Now, so moving on into talking about the substitute decision maker. So, when we say this patient basically cannot take decisions regarding treatment, he's schizophrenic and basically doesn't understand anything, and then we need to move on into his relatives. Okay. So قانون الأحوال الشخصية is the one that we go to. Like in the West, basically there's a hierarchy that's we usually follow, which is basically part of the Healthcare Consent Act or the SDA Act, which is the Substitute Decision Act. Okay, but in Kuwait we depend on قانون الأحوال الشخصية. ونفسه طبعا هو ناقص يعني, but we still that's the only way we can use. So فالولاية على النفس تكون أول شيء للأب ثم للجد. Okay, so those are the first people we need to go to. Okay, فلأي شخص مثلا نقول إنه okay هو غير قادر, we have to automatically go حق الفاذر أو الجراندفاذر. Okay, إذا الشخص طبعا هذا طبعا اوتوماتيكيا يصير الشيء إذا كان قبل إذا تحت 21 سنة. هذا شخص تحت 21 سنة سواء ذكر أو أنثى اوتوماتيكيا هو الأب أو الجد. أوكي. بعد 21 سنة لازم هني نحدد هل هو ذا فعلا غير قادر بسبب الجنون, فكذي الحين نقوم نستخدم القانون. أوكي. ففوق 21 لازم يكون بسبب اللي هو شخصنا المريض عنده سكيزوفرينيا وقلنا أنه غير قادر, لذلك نحط له قيم. اوكي, فنلجأ للقانون هذا, فيكون اول شيء الاب ثم الجد. اذا مو موجودين الاب ثم الجد راح نلجأ حق الاسباب النفس. اوكي, فهم راح يكون بالترتيب هذا الابناء بعدين الاباء, بس الاباء لان اوريدي مشموله فوق فراح تلغي هذه. اوكي, لان هذا هو النص نفسه الموجود بالشرع. اوكي, فاحنا راح نتبع التقسيمه هذه, اول شيء الابناء بعدين الاخوان بعدين الاعمام. اوكي, طبعا قانون الاحوال الشخصيه لانه قانون شرعي ما الانثى ما لها دور. اوكي, فما يصير ناخذ مثلا الديسيجنز من الزوجه مثلا. اوكي, الا اذا في حاله المحكمه عطت الصلاحيه وحطت الزوجه انها تكون كقيم, اوكي شيء ثاني هذا. اوكي, بس اذا ما في قانون من المحكمه ما نقدر, بس ان نتبع القانون نفسه ما نقدر. اوكي, وطبعا ما نقدر حتى الزوج نفسه, العصبه بالنفس هم الوارثون من الرجال ما عدا الزوج, حتى ما نقدر نلجأ للزوج again الا اذا في قرار من المحكمه. اوكي, وهذا لاسباب شرعيه طبعا, لانه يمكن الزوج يكون في خلاف مع الزوجه يبي يأذيها باي شيء يعني, ف we can't take the decisions from الزوج. Although I mean logically it should, because I mean that's basically the law in Canada, for example. The first one in the hierarchy is basically partner, which basically goes for both, either the husband or wife. Okay. Next week, by the way, we're going to have a discussion about the same elements. A lawyer is going to come, an ethicist, so we'll have more questions about those things. Okay. So those are the description of الولي. اوكي اللي هو substitute decision maker انه لازم يكون طبعا امين القاصر. اوكي he should be able to take care of him. Who basically is capable by himself, right? He should be capable, just like the law there, that the person should be capable, willing, and available. But the ones in here saying basically amin al-qasir, which is really, I mean, that is willing, قادر على تدبير شؤونه، متحد معه في الدين. Okay? فإذا فقد الولي أحد الشروط سلبت ولايته. Okay? في حالة عدم تعيين ولي على القاصر أو سلب الولاية تعهد المحكمة بالقاصر إلى أمين أو جهة خيرية، فالمحكمة لها القدرة. خلينا نفرض there was a conflict with the family, okay, and this is exactly what we used to do in Canada as well. When the family basically they're not cooperative, we go to the court, tell them the family are not cooperative, they're against treatment, and the person really needs treatment. So they issue basically something that says what they call the PGNT, a public guardian trustee, which is a non-profit organization that take care of the patients. Okay, so in here the court can assign, for example, this non-profit organization with a human rights or something to take care of the patients. I've never seen it, but I'm sure they can. Okay. If we compare the list with the one in Canada, for example, you see the hierarchy there that starts with the guardian of the person, then the attorney for person in care. This one basically that has اللي هو قرار من المحكمة, and then the board, and then a spouse or partner, and then child or parent, and then parent with access rights, and then a sibling, and so on. And the last is the public guardian trustee. Okay. And there, for example, they also have a description for the substitute decision maker that should be capable, should be available, should be willing, and not prohibited by court order, and the age, at least age 16. Okay, so let's move on, talk about a little bit about the informed consent. Okay, so when we say I took a consent from the patient. So the first thing is capacity. We need to assess capacity. Is the person capable or not? Okay, and we understand that by saying capacity, we need to assess whether the patient understands and appreciates the information. Okay, so depending on that, whether he is capable or not. Okay, at the same time, when we say capacity, we need to discuss basically consent. Okay, so he needs to understand the information. Which information? The information about the treatment and the condition. And this is consent. Okay, so we need to take informed consent from the patient. So consent in general should be related to the treatment. Okay, so when I give him, for example, Zyproxa, the consent I discuss the olanzapine, Zyproxa with him. It's not that I give him Zyproxa and then discuss with him insulin, for example. It should be related. Should be informed, and we'll go into detail about that. What do we mean by informed? This is very important. Okay, it must be voluntary. Okay, I cannot force someone and then say, "Yeah, I took informed consent." No, it should be voluntary. It should not be obtained through misrepresentation or fraud, and I think this is a really, really common mistake that's happening here in the hospital. People give Seroquel or Zyproxa to patients and tell them this is for sleep. Ouch. This is, guys, very wrong. You can easily be sued for that. Seriously. Easily can be sued. Okay? Basically, this is a fraud. You're lying to the patient. Zyproxa is not for sleep. Seroquel is not for sleep. They are antipsychotics. And they need to know that this is antipsychotic. This is for delusions. This is for hallucinations. This is not for sleep. Okay, be careful. All right, I cannot support you if you guys do that. Okay, so the elements of informed consent. When we say a consent is informed, what do we mean by that? So the patient needs to have all the information necessary about the treatment, nature of treatment. This is an antipsychotic. This is a mood stabilizer. This is not a sleeping medication nature of the treatment. Okay, they need to understand that. They need to understand the expected benefits. Give them Zyproxa, I'm giving you this antipsychotic. It basically lowers down the dopamine. Okay, and basically the reason for it is to lower the delusions and hallucinations that you're having. Okay, and the material risk. The material is basically the common and the serious. Okay, we don't have to tell them all the side effects. You can't really cover all side effects. You'll take a whole day covering all side effects. So you just need to tell them the common side effects of Zyproxa. Okay, this is an antipsychotic. It's very common that you'll have metabolic syndrome, you'll have weight gain, can cause serious risk with NMS and sudden death and those things. Okay, so the common things, not necessarily everything. Okay. And alternative course of action. Okay, so I'm giving you olanzapine, but there are different antipsychotics that we can use. Although I prefer using olanzapine because you have sleeping issues, and this helps. So, however, we can use some other antipsychotics. And then if he asks you, okay, what other antipsychotics, you tell him. You tell him the different options, and it is his right to choose. Okay. Likely consequences of not having treatment. So you basically told him about the expected benefits. Okay, I'm going to give you olanzapine, and this is the benefits from it. And then you tell him the alternatives and what are the prognosis without. What can happen if he doesn't take olanzapine. Okay, and then basically he needs to have enough time, or you give him enough time, basically to ask questions and answer them. Okay, so what I usually do when I give, for example, a new medication, I'll tell them this is all the information about the medication, the side effects and that, and then I give them a printout about the medication. This is olanzapine, this is the common side effects of risk and all that, okay? And tell them to go and read it, okay? And consent may be withdrawn at any time. Maybe he's accepting now about olanzapine, and then he'll come in 2 weeks and tell you, doctor, no, I don't want to take it. It's okay. He doesn't want to take it. It's fine. It's up to him. Okay. So again, you go into telling him about the alternatives, other medications. Okay. So then consent in general. So it is, as we say, that it's informed, which basically detailed. You give them all the information about the treatment. Basically, you guys, think of it, put yourselves in the shoes of patients, okay? And you go to a doctor, and basically the doctor doesn't tell you what you have and gives you a medication and tells you this is for sleep. And then you realize later on that this is actually whatever, like a mood stabilizer, antipsychotic or something. How would you feel about that? I'm sure you're not going to be very, very pleased. So if you don't accept that yourself, you should not accept it to your patient. Okay, that's basically the general rule. Okay. So the consent can be written or verbal. Basically, verbal is you talk to the patient says okay, or written, that you give him a piece of sheet and then he signs. Preferably should be written, so you keep it in the record, you keep it in the file, so that later on, when he says, "Oh, doctor, he didn't explain that to me," you don't have a proof. But with the written, you have a proof. Okay? Maybe expressed or implied. So maybe the person can say, "Yes, I agree," or just nods, implied. Okay, so you understand it's okay. In those cases, if it's verbal or implied or even expressed, you have to write down in the notes. You have to, if there is no written consent, you have to write a note saying, I did assess capacity of the person, the patient understands and appreciates the benefits and risks of the treatment, explains all the material side effects and risks, and the patient is in agreement. That's it. Just 2-3 lines, okay? That will protect you, okay? So later on, if something happens, If this patient has a heart attack or arrhythmia in the ward and dies suddenly, lawyers will go to the chart and we'll see, did you guys assess capacity or not? If they don't see those 2 lines, the 3 lines that you assess capacity, you're a goner. You're in deep trouble. Okay. Okay. Of course, the exception to the rule of informed consent is emergency. If you see that this is an emergency, then you can treat without the need for informed consent. Okay. Okay. So I made a form basically, which is kind of similar to, just a second, I have it here. So this is a form that we started actually using in forensic for patients who we say that they're not capable regarding treatment, okay? It's very easy to do, 8 pages. It won't take like 10 minutes of you, but will save your life, okay? So we will start implementing this form for any patient that you say that he is not capable regarding treatment. You have to fill this form, okay? Basically, I took the same kind of form that we've been using in Toronto at the CAMH, the Center of Mental Health and Addiction. I modified it a little bit and added, of course, the translation, okay? So it covers all the elements of the history and all the tests that we've been talking about, the informed consent, about assessing capacity and that. And then at the end, basically it's like a tick box where you say patient is capable regarding treatment of a mental disorder, yes, or patient is incapable regarding treatment, okay? So this is gonna be enough for you guys to keep it the chart or the file, and it will save you, okay? So in case you say that this person is not capable and you go to his family, you're covered with this, okay? But if you say he is capable, you can still continue using the form, okay? So you'll be even more protected at least. So you say, okay, I assess capacity, he is capable, okay? Now, let's talk a little bit about this review on capacity board that will start hopefully next week. So I've been working with this with Dr. Talal, and we're working on translating the whole thing, although we honestly don't see a big value in translating the whole thing because it's mostly going to be used by doctors, but still. So it is going to be an internal policy, okay? So it's here, but this is a policy of the hospital. And the idea of it is that it's very similar to the review board that we do in other countries where there is a mental health act. Although we don't have a mental health act in Kuwait, but that doesn't mean we cannot use or make internal policy. We can, and we should, okay? So a review on the capacity board will be formed as a measure to balance the rights of vulnerable individuals with public safety. Vulnerable individuals, we mean basically psychiatric patients, okay? The board will regularly review cases regarding issues of involuntary admission, detained forensic patients, incapacity regarding treatment, and lengthy admissions. Okay. So in the policy, we divide them into different categories. The first category is talking about a right advice. Okay. So basically, all patients, before they get admitted, they should be informed about their right to get a hearing from the review and capacity board. كل شخص له الحق إنه يعرض على اللجنة، هذه لجنة المتابعة. Okay, المتابعة والأهلية. So first, When do we do that? The admitting physician, for any admitting physician, you guys, for example, are on call in the emergency and you're admitting a patient, okay? So if you're admitting a patient involuntarily, basically his family sign for his admission, okay? If he signs for his admission, that's fine, that's good, that's voluntary. If his family sign for his admission, then you tell the patient, you have the right to ask for or request a review on capacity board, okay? So we clarified this, that admission basically starts the day of admission to the admission wards. So hopefully the next few weeks we'll open Ward 38. Ward 38 is going to be the assessment and triage ward. And this will be a ward only for assessments, for up to 3 days admissions, okay? So in that ward, basically, the patients are not considered admitted. They are admitted for assessment. They're not admitted physically, okay? So those patients will not gonna make a review board for them. For only patients who are admitted to the admission wards, they will be having the ability or the right to request for this RCP, okay? And basically it is the duty of the admitting physician, any admitting physician admitting the patient involuntarily, meaning the family signs for their admission, you tell the patient, you know that you have the right to be seen by a review board in case of you not agreeing to be admitted, okay? The second element to this, or the second option for asking the RCP, is that any patient deemed incapable. When we talked about seeing a patient who is not capable, and in that case we inform the patient that, again, it is your right to ask for a review on capacity board, okay? So what happens then if the patient requests, the patient says, okay, yes, I agree, I need to see a review board, okay? In this case, the admitting physician or the treating physician, okay, basically calls Dr. Talal. He's the person in charge of the RCP, tells him I have this patient in Ward 41, and he basically, I found him incapable, and he wants to be seen by a review board. Then Dr. Talal, within 3 working days, he should assign 3 senior psychiatrists, okay? So senior psychiatrists, meaning any senior registrars and above, from different units, basically. Different units than the unit the patient is admitted to, okay? And those 3 psychiatrists will meet with the doctor and with the patient and basically see why the patient is admitted. Is he really needs to be in hospital or not? Or is he really not capable or not? So basically, this board will protect you guys, okay? So it's gonna be like a second opinion. So I admitted the patient against his will, which I think he's a risk to others or risk to himself. The review board will come and see him and find this true, actually, he is suicidal, he needs to be in hospital. The board will protect you. You say that I'm keeping him, okay, and the board themselves actually, they agreed with me. So you feel really protected, okay? At the same time, it will protect the patient. Let's assume that basically we made a mistake, that we admitted the patient against his will and he's not suicidal, okay? Just because, I mean, we, or the family of the patient wants to admit him, okay? So in that case, the board will say, no, he doesn't need to be in hospital. Okay? So the board will protect the patient. So it's a win-win situation. It protects you, protects the patients. Okay? So the review and capacity board, when would those boards deal with the patients for involuntary admissions? For any patients is admitted involuntary, that basically family signs for their admissions, then automatically the admitting physician tells Dr. Talal about this, and it's up to basically the patient if he, no, sorry, first, of course, I mean, the admitting physician talks to the patient if he wants to have an RCP or not. If he wants, then yes, then the admitting physician talks to Dr. Talal, and Dr. Talal will assign a board. Okay. If the patient, maybe you ask the patient and tell him you have the right to do that, and then the patient say, no, I'm fine, I'm okay. That's fine. Okay. You don't need to assign a board for him. Okay. So for involuntary patients, so basically what happens is, I mean, if this patient, the board meets with him and they say, yes, the patient needs to be in hospital, okay? So in this case, patient needs to stay in hospital, and then another review board will happen after 30 days from the time of the first review board, just to see what happened during this time, okay? Did we treat the patient, or were we just wasting time? Okay. Okay, and of course, the onus is basically al-atiq. The onus is on the treating physician to prove that the patient needs admission. Okay, so the admitting physician says that the patient needs admission. The treating physician needs to prove that he needs admission. It's not the patient that he needs to prove that he doesn't need admission. Okay, so the board meets with the doctor and the patient. The doctor needs to prove to the committee or the board that the patient really needs admission. Okay. Also, the board will deal with detained forensic patients. For all forensic patients who basically we say that they are ready for discharge. So what's happening now, when we say a patient is ready for discharge, we just basically talk to the court. Okay. Now, what's going to happen? Any patient we say that he's ready for discharge automatically will make a review board. A review board will need to see the patient and see if he really is good for discharge or not. Okay. Also, there's going to be an annual hearing for all detained patients, because what's happening now, patients at the forensic, they've been there for years, nobody knows about them. Okay, it's only us in forensic, we see them, but are we doing a good job? I don't know. So it's going to be better if there's a review board. Okay, another psychiatrist going to look at this patient and say, guys, what have you been doing all this time? It's been a year. Did you do anything? Did you start treating the patient? Just giving them passes? Okay. So I think we desperately need that. Okay, again, the onus is basically on the treating team, on the forensic team, to prove that this person still needs to be in hospital, that he's still a threat or significant threat to the public. Okay, so if the board sees that he's not a significant threat to the public, then okay, the treating team should then speak to the court about this, and he should be discharged. Okay. Patients deemed incapable, again, so if the treating physician assess capacity and say the patient is really not capable, then he tells the patient, okay, I'm going to assign a substitute decision maker for you, family member, but you know you have the right to ask for a review board. If the patient agrees, then a review board meets with the patient, okay, and the treating physician. The treating physician has the onus to prove that this patient really is not capable regarding treatment, okay? And the last thing is lengthy admissions. All patients in hospital who've been in hospital for more than 30 days automatically will be seen by a review board, okay? Automatically. So, any of you guys have patients in the wards, subacute or chronic, and the patient has been there for more than 30 days, will automatically be seen by a review board. Yes, I mean, there are a lot of patients like that, and it will take a lot of time doing review boards, but we should, because a lot of patients like this are in wards and nobody knows about them, okay? So after If a patient's been there more than 30 days, we'll assign a review board, and review boards will meet with the patient and with the doctor. What have you been doing all this time? Okay, that's going to be basically the question. Maybe they do need to be in hospital. That's a different thing. Okay, but we need to do that. We're desperate for that. Okay, so after 1 month, let's say we met with the patient and we thought, okay, he needs to be in hospital. And then, so basically he stays in the hospital, and then, so the second review board is going to be after 2 months from the first, and then after 3 months from the first, and then 6 months after, not the first, after the previous one, okay? So basically, I mean, we're really reinventing the wheel here. I mean, we're just following other mental health acts. It's not something new. This is commonly done, I think even in Egypt, you guys, I mean, are aware of this. I mean, we're not doing something new, okay? We're just basically, we're desperate, we need the mental health act, there is no mental health act, okay, well then we should do something about it, okay? Again, the onus is basically going to be the treating team that the patient needs to be in hospital, okay? We clarify the reason for involuntary admission for any patients coming from emergency, and we admit them. We make the family sign for their admissions. There has to be certain criteria for that, okay? That the person requires care, supervision, and control in the hospital to prevent the person's substantial mental or physical deterioration. The person is really very mentally sick, that he's not doing well, he's at home to himself, he's not eating well, he's catatonic or anything like that. He's at risk, then we can admit him, okay? Also, if, for the protection of the person, he's suicidal, then we can admit him involuntary. Or for the protection of others, that basically he's homicidal, okay? Then we can, okay? And I personally spoke actually to البحث القانوني بالوزارة, and it says actually we can admit patients if they are of risk to others and to themselves, okay? So we can. I really hope next week he's gonna join us. I spoke to him and he said he's gonna see if he's able to come next week. But yes, we can, okay? We can admit patients involuntarily to protect the society and protect them, okay? Of course, at the same time, so when we say that this person, we need to admit him for the protection of others, at the same time, we cannot suitably be admitting him as a voluntary patient. So if the patient can be or suitably admitted as a voluntary, then we admit him voluntarily, okay? Right. This is the form that we're making. Again, Dr. Talal is working on this. So this is the request for review and capacity board. This is the admitting physician, okay? And here saying, so the admitting physician or the treating physician fills this form, and he basically ticks the box here. Is it for involuntary admission or incapacity regarding treatment? And this is basically if the patient requests the RCP. If the patient says, yes, I want RCP, then the admitting or treating physician fills this form and takes this box, whether it's treatment or incapacity, and notifies Dr. Talal about this, okay? At the end of this form, it's not shown here, that there is an extension to it. Basically, at the second page, it says, this is if the patient refuses the RCP. If you ask him for RCP, he said, no, it's okay, I'm okay, I don't want it. Then he needs to sign that you did discuss his right to have an RCP, and he refused, and he needs to sign it, okay? So later on, we have a proof that we did tell him. He refuses, it's up to him, okay? But we did tell him his right, okay? The last thing, last form is, this is the finding of the RCP itself. So the three members or three doctors of the review and capacity board, when they meet with the patient and physician, they decide, okay, was the involuntary admission necessary? And then they write their reasons. Or involuntary admission was not necessary. If they say it's not necessary, that's it. The patient really needs to be discharged, okay? Or the treatment is really patient is capable regarding treatment, or patient is not capable. And if not capable, he's not capable regarding what? What type of treatments, okay? Okay, and then signature of the three members, okay? So, at the beginning, we'll do this as an internal review board, okay? But I already spoke with the ethicists and lawyers, and we're basically going to ask the ministry if we can involve external members even to be in the board, because I mean that will be really more transparent, okay? But the problem, of course, we don't have mental health act, so the problem will be about confidentiality. Is it okay for someone from outside to see the file of the patient or not? That's going to be the issue, right? So if we make it official thing that the decision comes from the ministry, then we can, okay? And we're working on this actually, okay? So at the beginning, we'll start with the internal review board. I think it's really better than nothing. It's much, much better than nothing. It will protect you guys. You'll feel safer about keeping the patients against their will or treating the patients, okay? And protect the patient's rights. You'll see a lot of patients being discharged from the hospital. A lot of patients have been staying here for months, years, for no good reason. And this is not ethical, it's not right. We really need to discharge them, okay? I think that's it. Any other questions? Oh, you didn't ask the questions, so should be any questions?
Regarding patients who has no family, like homeless or housemaids brought from what?
Good question, very good question. I think in this case, the review board by itself is going to be enough, okay? Again, it's better than just the treating team. So the treating team will have the decision with the review board. They will feel supported, okay, that we really need treatment for this patient, and even the review board is actually agreeing with us. So your decision going to be really having a lot of weight, right? And of course, we can involve the ministry in this case. For example, the khaddamat and they come and we can involve their ministry in this, okay? But the decision of the board by itself going to put a lot of weight to the decision of the treating team, okay? Yes, that's a very good question. We did consider that, and it is a problem. I agree with you. Yeah. Yeah. Okay, two of you. Yeah.
Okay, most of the long-stay patients are in the hospital not because the admission is necessary, but because the families or their families are refusing to receive them. So suppose that they were seen by this board and
right.
they decided that the admission is not necessary.
Yeah.
And what is in this case, what is the next step?
Yeah.
When we discharge them on their own or what?
Again, very good question. We did consider that. It's going to be actually a huge problem, right? But now, when you discharge the patient from your unit, you'll say, even a review board is agreeing with me that this patient needs to be discharged. So when you say khuruj idari, you feel really protected, okay? That's even a review board made of different doctors from different units. So this is really not a personal decision. It's not because I hate this patient, I'm discharging him. No, because it is not right that he should be here, right? So the decision going to be basically going to have a lot of weight, right? So if they refuse to discharge him, then we can even talk to lawyers about this and say, even a review board is actually saying that he shouldn't be here in the hospital. Yeah. Yeah.
Thank you about this. Again, we try to review our practice and we try to improve our experiences.
Absolutely.
Yeah, it's a major qualitative change here in our practice, and also for the form of the changing the policy.
Absolutely. Yeah.
But we have many problems. Firstly, I would like to discuss,
Sure.
for our time, regarding the logistics, means the number of the CNUs that will be taking over
Right.
most of these cases for the usual
Yeah.
chronic cases, new involuntary
It's true.
cases, for
It's
forensic
true.
cases, and so on.
It's
This is
true.
one point. The second, that we don't have زي ما بيقولوا عندنا ما عندناش بالعربي كده قوة إنفاذ القانون، أو زي ما بيقولوا
صح.
إن whatever our decisions, we will facing that there is no rule
صح.
or no law who support our practice or policy. This is still internal.
صح.
Anything, any form that is not supported from the ministry,
Yeah.
from the law, it will be just an internal policy and may or may not. This is the second point.
Yeah.
The third point is the cultural, meaning that we have many patients who are admitted against our advice. We don't and they all stay against our advice.
Yeah.
Mean that let me give you example. One patient who are having and we're facing this many times. One
Yeah.
patient, female, who have a psychopathic traits, borderline traits, or something like, or even some social problems, and they try to go away from the family rules and culture.
Yeah.
They admitted here against their advice, and the review board came and say that she has no mental disorder, means
Yeah.
that need involuntary admission, and so will discharge here. And if you try to do this, the family will raise a case about you, and then it will be a problem. And we're going into the ministry and say that, and so
Yeah.
on, so on.
Yeah.
I say that it's a very good to discuss this and these difficulties and try to overcome before we are going. Let us to go through this and
Yeah.
know
Of course.
how you think about
Of course. I mean,
problems.
we should always, review the plan, right? I mean, we should. Of course, we're going to face obstacles. I mean, that's very, very natural, right? I mean, it's very expected. It's going to happen, but we will review it and we'll change it. Whatever happens, we're going to change it. We have to weigh the benefits and the risks again of this, right? I think the benefits really outweigh the risks in here, really. We have a lot of benefits going to be. Just imagine. Didn't you have a lot of times in the past where you needed a second opinion, you needed a committee that they agree with you that, yes, this patient needs to be in hospital, this patient doesn't need to be in hospital, this patient needs treatment. I'm sure all of us, we experience that on a daily basis even, okay? So I think really the benefit is really high of this. If there is no law, that doesn't mean that we shouldn't do it. Okay. Again, I always say ethics come first. If you think what you're doing is ethical and you're not doing it for personal reasons, honestly, you shouldn't worry about anything. Because the court at the end, let them sue us. Seriously, I want them actually to sue us about this. So they would make law. Okay. Because, they won't see how important this is until people start escalating the issue. Okay. So let them sue us, and I will happily go to court and I tell them, I'm a psychiatrist, this is my profession, and I believe the patient really needs to be in hospital, he's at risk, I'm saving the society, I'm saving him from killing himself. How would a judge tell you this is wrong? There's no such thing. He can't even tell you this is wrong. Can't, okay? Even the ministry actually, they agree that they say, yes, we can, okay? So again, not having a law doesn't mean we shouldn't do it. We should not even wait actually for the mental health act. Of course, it's ideal to have a mental health act, but if we don't have it, work on ethics, right? And we're following rules from other countries, the usual rules for the profession. We're doing the usual rules. When we go to court sometimes, and even in forensic, they asked me, I remember even they asked Ammar himself one time, when he asked about one case, and it's not written in the law in Kuwait, they asked him, do they do that in other countries? He said, yes. It's okay. So you're not doing something from yourself. This is not negligence, what are you doing? If it's not negligence, if you're acting in good faith, good intentions, you shouldn't be worried. Okay? Yeah.
هو في قانون بيحكم العلاقة بين كل المريض العقلي وقفوا في المستشفى اسمه قانون الامراض العقليه. في منه قانون الامراض العقليه المصري سنه 44 والكويتي معدل من المصري. لو دخلت على جوجل وكتبت قانون الامراض العقليه هتعرف القوانين اللي بتحكم الدكتور والخروج وحقوق المريض وحقوق الاهل وكده.
ما في قانون كويتي؟
في قانون الامراض العقليه الكويتي. انا مثير عندي على كده.
اتوقع انت الوحيد اللي بالقاعه اللي عندك القانون هذا. اسمع عن في قانون تنظيم مهنه مزاوله الطب. هذا القانون الوحيد.
الامراض العقليه.
لا ما في شيء. ما في.
المصري طلع سنه 44.
يمكن المصري اكيد.
وبعدين الكويتي معدل منه.
لا ما في. ما في.
بس خش حضرتك على جوجل
انا اقول لك من غير جوجل يعني انا 100% اقول لك انه غير موجود. اوكي يعني هذا
انا اجيب لحضرتك.
اوكي جيب لي. هو قانون موجود اوريدي مو موجود. هو القانون اللي اشتغلوا عليه الشباب دكتور عادل الزايد سليمان الخضاري عبد الله الحمادي اوريدي ترى وافقوا عليه. بس اللجنه التشريعيه مجلس الامه للحين ما اشتغلت عليه ما اقرته. فهو موجود اوريدي الدرافت الصيغه موجوده. اوكي ها؟
ما فيش الفاينل درافت؟
نو ستيل نوت ابروفد. اوكي نوت ابروفد للحين. مجلس الامه لازم يوافق عليه اللجنه التشريعيه. طبعا مجلس الامه ما شاء الله عليهم كل يوم منحلين يعني فما عندهم وقت اصلا يطالعون القانون مالنا. ف we don't know when it's gonna happen. اوكي يعني حتى دول الخليج ترى احنا كنا يعني الاسبوع اللي فات انا كنت مع دكتور عادل الزايد في لجنه هذه الصحه النفسيه لدول الخليج. كل دول الخليج ما عندهم القانون ما عدا السعوديه اللي هو من 2015 اقر عندهم وقطر اقر عندهم الاسبوع اللي فات اكشولي قانون الصحه النفسيه. يعني الامارات البحرين عمان مو موجود عندهم قوانين. although كلهم نفسنا already عندهم درافتس بس لهن البرلمان لازم يوافق عليهم. اوكي. Yeah.
First of all, we will need a handout from the presentation.
Oh, you will have them, of course.
Printed or soft copy.
Sure. I'll send them PDF to the group. Yeah. Yeah.
Second, the lengthy admission and putting a cut-off point of 30 days.
Yeah.
Actually, you know, in psychiatry, staying in the hospital more than 30 days is the rule rather than the exception.
You're right. No, you're right. That's true. That's true.
Isn't it too short? The drug trial itself takes more.
That's true. Again, a review board is not something that means you have to finish it in 30 days. It just basically, you know, it will look into the patient and you, basically, what you've been doing. So for you, rather than using defensive medicine, and give them small doses and taking your time. No, I mean, use this time and basically treat well, okay? So that's the idea of the review board. Most of review boards, I remember even like in Canada, more than 90% of review boards, they agree with the doctors. They rarely actually disagree with the doctors, really. Even, I mean, and most of them basically they're not psychiatrists, maybe one of them usually is a psychiatrist. But most of the time they agree, more than 90%. Yeah. So a review board is really mostly to protect you guys, right? So in case something happens, say, review board actually agreed with me, guys. So you really feel protected. Yeah. All right. Yes?
Regarding the disposition of some patients who have been hospitalized for a long time.
Yeah.
I think we are facing the other face of the point problem.
Yeah.
Is that there is lack of intermediary homes like nursing.
Absolutely.
Like,
Yes.
This is the issue.
That's true.
This is one.
That's true.
It's a whole system that needs to be adjusted.
There's a lot needs to be done.
The other one, even
Yeah.
providing those places like daycare.
That's right. That's right.
Would be good first step so that.
I don't think, no, I totally disagree from that being a first step because, I mean, this will take ages, right? So, look, the idea of the board, even if we clear third of the patients we have in hospital, that's really a good achievement, really. I mean, we should not have high expectations of clearing all those chronic patients. If we clear third of them, that's really a good achievement, okay? So now we're going to start a day program. Dr. Abu Zaid will work in it, and we'll start an outreach program too, okay? So those will clear up some of those patients, right? So those chronic patients now, they don't have an excuse. We have day program, we have an outreach program, so basically they will have this long follow-ups. Okay. Yeah. Okay, thank you guys. Thanks.